So basically what we need to know, this is very, it's not showing up quite right. You will get this chart in the MRCP website, the Royal College website, that what list the examiner is holding in his hand, what they want to see from you, what they want to hear from you. There is exactly written what will give them a satisfactory response, what will give them a borderline response, and what will give them a unsatisfactory response. So you have to go through these in very details before the exam, so that you know what you are expected to tell, what you are expected to show, and what you are not expected to show. That's very important, that you don't do anything that's not expected. So from the basics, everyone has gone through this. You have to greet the patients. That's very important. Whenever you get the session, practice with the good afternoon and good morning every time. Hand wash, introduce yourself, ask for the consent. Bare below elbows is one of the very important things, which at least in the UK centers it's 100% compulsory. I have been in a Kerala center, they also practice that. I'm not sure whether they allow any rings or not, but in UK centers they allow nothing. So nothing below the elbows, no rings, no bangles, no shirt, nothing. So that's important. Confirm the patient's identity. You will be given a name or a short name like AJ or whatever. So that you have to confirm. And exposure is important. Usually they keep the patients exposed for that station. If the patient is not exposed, then you have to ask for the exposure. Then grossly from the bed end, you have to see. For abdominal case, the important things are the shape of the abdomen. If there is anything gross, obvious, that's any scar mark or any obvious signs of chronic liver disease, or any dressings or plasters. Mainly if they have anyone who had a recent paracentesis, you will get a bandage here in one of the inguinal fossas or something like that. So that is important to note from the bed end. Next is the sequence of examination. So ideally, because you have, if you have a very short time to complete the whole examination, you should go in a rhythm. So it's not possible, because you are appearing in different stations one by one in respiratory, neurology, abdominal, and cardiology. It's not possible to remember that, oh, this is cardiology, I have to see this 1, 2, 3, 4. That's not possible in the same go. So what I would suggest is that you start in a fashion that's common for every station. You start from the hands, go proximally to the axilla, shoulders, neck, then you go to the head and neck, the face, and then go to the system proper. This is basically mainly important in gastro, respiratory, and cardiology. Neuro is a bit different, because they will tell you to examine either the limbs, either the cranial nerve. So that's a bit different, as Sir was telling, that there are 3 approaches. So neurology is a bit different, but in the other 3 stations, if you go systematically, if you go from the fingertips to the shoulders and then the neck, you'll remember what you need to see. You don't have to remember point by point, I have to see the pulse, I have to see the water hammer pulse, whatever. If you go nails, yes, palms, yes, then you go for the small joints if needed in any case, then you go to the wrist with the pulse. In cardiology, you have to go into details about the pulse, but in gastro, you don't need to get into details. Just the pulse for 15-30 seconds would be enough. Then you go, if there is any AV, fistula or anything in the gastro station, you go for that. Then you go to the shoulders and neck, you go for the neck glands. Then you go to the head and neck, and so palate, sinus is inside the mouth, gums. And while you are doing this, keep the patient seated so that you can examine the back at the same time. In the back, so hands, you can start, as I said, you can start with both hands together, dorsum, then the palm, nails, pallor jaundice, palmar erythema. Flaps is very important in the abdominal station. So even when you are starting, you don't know whether it's a liver case, whether it's something else, whether it's kidney case, but go for the flaps, just for the sake of the test, that you know what to see in an abdominal station. Then comes the forearms and arms. Yesterday there was a case with the AV fistula, so it was the only proper finding in that case, to be honest, other than some ascites. So that you have to see, and you have to determine whether this is active, non-active, things like that. Any injection sites, then when you go to the back, you see the scars, if there is any nephrectomy scar, or if there is any skin changes related to diabetes, related to chronic liver disease, because that's the most extensive skin that you can see, most likely to show you things like caput and sorry, not caput, the spider nevi and things like that with veins. So that's then with the head and neck, you can go for the cervical nodes. In gastro, cervical nodes are important because of the trocheus sign. They may ask if there is any node with ascites, then differential will come as any gastric malignancy which is showing ascites and the cervical lymph nodes. And pallor jaundice, you know how to see. I would suggest, if possible, if communication is easy with the patient, if it is the same language you are using, then let the patient pull his eyes down, like the skin down, let the patient pull his upper eyelids up. That will help. The less you put the patient in any strain, any pain, the better for you in the exam. So if you are able to communicate with the patient, if there is no language barrier, ask him to pull the skin down. In the UK, all patients will follow your English to do that, because that's what we used to do even in clinical practice. We would not go and put the skin down, they will do it themselves, we'll just have a look. So that's something you can consider. Tongue, oral cavity, and so in the abdominal case, my focus is mainly on CLD, but if it's a transplant case, be a kidney transplant, be a liver transplant, you have to see whether there are any side effects or any chronic effects going on with steroid therapy or any immunosuppression. That's one of the important points. So you have to see side effects of cyclosporin, any steroid side effects that you can see in general survey, in the head and neck, in the body, you have to consider those. Next is the proper thorax abdomen inspection. So there would be, you have to look for scar marks, mainly for the nephrectomy scar mark, liver scar marks, and transplanted kidney scar mark as well. So those are important, you have to see. So these are the classical ones, the pictures, photos are the classical ones, but there may be other scar marks as well. Go through Google, you will get hundreds of scar marks related to liver transplant and kidney transplant. Have a look and see what are the common areas that we go with a nephrectomy or a liver transplant, and you will you have to mention those are important signs. Other than that, there are the spider nevi, caput medusae, varices, and diabetic skin changes. So the patient yesterday also had the diabetes changes, so you have to mention that as well, because yesterday's case was only diabetes and then chronic kidney disease with end-stage renal disease. So diabetes marks are important in that case to determine the etiology. Of course, if there is any sign of being a kidney case, you have to see for transplanted kidneys. Sometimes they are hidden because it's mainly towards the groin, and with someone who is obese or something, you cannot see them directly, so you have to try to find that out. That's important. In a kidney case, if you miss the transplanted kidney, it's difficult to pass. So that's important. Palpation wise, ask the patient number of times whether there is any pain at all. If there is any pain, try to avoid that area if possible. Go with superficial palpation slowly and ask the patient if there is any problem. After that, you go for the deep palpation. Deep palpation with single hand, with double hand, both are permitted. There is no advantage or disadvantage, whatever you are comfortable with. But the patient should not wince at all. You do this one and patient does this, that last part of marks will be lost. So patient should not feel any pain at all. Your hands should be warm, your hands should be clean, and do the palpation very gently, because finding signs is less important than keeping the patient comfortable. That's you have to remember in MRCP cases. Even in the practice, what they do in the UK, safety and to be gentle is more important than the diagnosis. Then comes the deep palpation, then the organs, liver, spleen. and the kidneys, of course. You should remember the kidneys. And the palpation of the spleen sometimes you can do with the percussion, because you are shifting the patient to one side and do the spleen at the same time. That will save time, and that will save some discomfort to the patient as well. So it's not compulsory, but you can consider that doing the spleen along with the percussion. For the if there is a transplanted kidney, you have to palpate, superficial palpate that, and see if there is any like a thrill or something going on there, because that thrill and bruit, if present, that will indicate some renal artery stenosis in the transplanted kidney, and that would be one of the complications to mention in the crossings. So percussion liver span is not very important in this exam. Only when you are palpating the liver, you should mention 2 fingers below the subcostal margin or 3 fingers below the subcostal margin. You don't need a centimeter or inches, or even liver span is not very important. Shifting dullness, just you can do it on one side. If you are getting something positive, then you can go for the second side. Otherwise, it's not very important to go both sides. And while you do the shifting dullness, then ask the patient to rotate on the right side so that you can go for the spleen at the same time if you want. That's with percussion. Then auscultation, for the peristaltic sound, one side is enough. Don't go on auscultating the whole abdomen for that. That's not very important, because they will not give you acute surgical patients in the cases. So just to show that you know that peristaltic sound is important, just one side is important. Then for the hepatic bruit, kidney bruit, you can go for that. If there is AV fistula, definitely go for some auscultation over that. That will help you know the patency and the activity of the AV fistula. Auscultation of back or the chest is not important in abdominal station. Only if you have ascites or something to show or indicate that there is a fluid overload, then you can go for the base of the heart, base of the lung, to see if there is fluid overload there as well. And the legs, did I mention the legs? Yeah, legs. So legs, you have to see if there is any edema or anything that's indicating towards a liver case. Not very important. So again, you have to thank the patient, and you have to help them, or at least ask them to get them back their dress or cover. And to the examiners, you have last line to mention is that I would like to go for these further tests, like in abdominal station proper groin examination, a PR examination, and bedside tests like urine dip and whatever you feel. If there is a diabetes case, then you can mention a capillary blood glucose and things like that. So this is mainly the examination. So the examination, you have to focus that you go in a sequential manner, because if you go to and fro or fumble in between, then they will feel that you are not very confident. That's the only thing. You have to make them feel that you are confident. And as Sir was saying before, consultants, they are looking for a chap who will be able to handle the whole night without waking up the consultant. That's what they want to get from you. So confidence is what they want, and the other important thing is that you are not doing anything unsafe for the patient. You are not putting the patient in circumstances that is worse than how they have come to the hospital. So these two things they want to see. Just you can, so that they are confident about your dealing. That's what they want to see to make you a registrar there. Right? So, questions. So there can be few. The first question could be, tell me your findings. So you have to give only the positive findings. Negative findings are important only to say that something you have ruled out related to that case. All negative findings is not important. So only positive findings. And if they say what is your diagnosis, as Sir was mentioning, proper full diagnosis with the complications that you can see in that case. So that is the diagnosis. If they say what are your differentials, then go 1, 2, 3. Even if there are 2 differentials, mention only 2. I would suggest not to mention why you are thinking that as a differential diagnosis, do not explain your differential diagnosis. Just mention 1, 2, 3, 4, 5. That's it. Then they will pick one up and ask you questions regarding that. Then you go on why you are considering this as a differential diagnosis. Then you can tell that. But with all differential diagnoses, don't try to prove that this is the reason why you are considering that. That's not needed. Then the main question that they ask is, how will you manage these patients? So if they ask you this, how will you manage, that means you have to tell them about the bedside tests, you have to tell them about the investigations, and then the treatment. So management includes the investigation and treatment. So management doesn't mean only the treatment. So consider that. Bedside tests, whatever usually is done, the urine dip, capillary blood glucose, ECGs, these things you have to mention depending on your case. Then comes the proper management. You have to tell about the blood tests. Don't mention about routine blood tests or common blood tests. Just mention the tests. Complete blood count, electrolytes like sodium, potassium, urea, creatinine, random blood sugar, whatever is ideal for your case. Then you go for the imaging. Imaging, just tell them the baseline imaging that you want, that I want a chest X-ray PA view, or I want an ultrasound of the whole abdomen, like that. Don't go into X-ray, then I'll go for a HRCT, then I'll go for a whatever scan. Don't go into second line, third line, or nothing. Just the basic steps. They may themselves, the examiners may pick up a complication or important finding from your case and then ask questions regarding to that. That this is what you have found, so what you will do with this one? What is your next step regarding this? So in that case, basic steps again. Don't go into details. Like yesterday, there was a case of the AV fistula, which may be infected, which may be thrombosed. So don't go for angiography or angioplasty or something like that. Just tell them, if there is an infection, I'll suggest a CBC and CRP as blood tests. If there is a risk of thrombus, I'll go for a venous Doppler to see what's happening. And then you call your consultant. You call your consultant, or you see the subspecialty doctor, I'll call a nephrologist, I'll call a vascular surgeon to see if there is a thrombus and proceed according to their plan. So that is very important, that they are asking only as a basic doctor that what you want to do. They are not asking as specialists. Because if you, as I was telling, that in a nephrology station, your examiner may be a cardiologist, and if you say something with angio and he gets it in his field, then you are gone for the day. So just tell the basics and that will be easy. That's it basically. So confidence and safety, that is the main thing that you have to see. And if you practice regularly in your day-to-day practice with these things, like introduce yourself to the patient, say hello, say good morning, and then these will be like the normal for you in the exam as well. You don't have to remember, oh, I have to say good morning, I have to say my name, I have to say, so this, make it a practice in your day-to-day life. That will be easier for you during the exam as well. Right? Any questions? And more of practice. So if you do examination in anyone, at your home, in your patient, and make a video, and then you see it afterwards, then you will find, as an examiner, you see that video, you will find what mistakes you are doing, where you are fumbling. You will see that you are going this side and again coming to the abdomen, going to the neck, going for pallor. So that fumbling you will see if you record the video or do it in front of the mirror. Then you will see, when you retrospectively see your own video, you will see what mistakes you are doing. You can correct that. And see more and more of patients, that will be easier. Even just dummy patients, you don't have to see proper finding patients. You go with the dummies, your friends, make a close circle and examine each other. That will give you the feeling that where you are fumbling. Okay, thank you.